It's now my pleasure to talk about hypomyelination with atrophy of the basal ganglia and cerebellum and TUBB4A leukodystrophies. As disclosures, I want to note that I received grant and in-kind support for our translational research without personal compensation from a number of our different pharmaceutical partners. I also serve on the scientific advisory board of several foundations, as well as in an unpaid capacity to several pharmaceutical partners. I want to specifically acknowledge our foundation advocates, including the Foundation to Fight HABC, the Rare Ruby Foundation, and the HABC Foundation in the UK. I also want to acknowledge our many partners, including students, Brittany Sharzar and Julian Curel, as well as Luis Garcia and Julia Hacker, as well as Francesco Gavazzi, Laura Dang, and Justine Schultz, my colleagues who have assisted with the natural history study, as well as Sunetra Sass, Akshad Ahmad, who perform a lot of our basic science and mechanistic studies in our lab. Importantly, HABC and TUBB4A-associated leukoencephalopathies are recent arrivals on the leukodystrophy scene. The disorder was first recognized by Mario Vanderver based on MRI pattern recognition, but due to the fact that it was sporadic in nature and therefore was not amendable to identification by the typical gene linkage studies used at the end of the 1990s and the early 2000s, it wasn't until 2013 that a collaborative team at the University of Queensland, our group then at the Children's National Medical Center and Mario Vanderver identified the molecular etiology in 2013. And so here now in 2020, we're only really beginning to grasp the molecular mechanism of the disease and focus on therapeutic development. So hypomyelination with atrophy of the basal ganglia and cerebellum is an acronym that underlines the MRI pattern of this disorder. It was recognized by Mario Vanderver due to the constellation of hypomyelination with T2 signal abnormality and relative T1 preservation of signal, as well as the presence of cerebellar atrophy, and then key features of striatal atrophy over time, particularly of the putamen and to a lesser degree the caudate, with relative preservation of the globus pallidus and the thalamus. This cohort of patients with these key imaging features typically had a late infantile onset with hemidystonia and gait dysfunction. These children experienced gradual motor decline with ectopyramidal and pyramidal abnormalities and also developed cerebellar ataxia and dysarthria. Over time, they suffered significant decline related to their oromotor dysfunction, as well as orthopedic and respiratory complications. When the gene was identified in TUBB4A, being TUBB4A, however, it rapidly became clear that there was a much broader phenotypic spectrum associated with TUBB4A mutation. At about the same time as we identified TUBB4A as being associated with the classic phenotype of HABC, two different groups also associated that same gene with DYT4 dystonia or whispering dysphonia, which is characterized by onset in the third and fourth decade of lives with speech changes and a very typical recognizable hobby horse gait. However, subsequently, it became clear that TUBB4A mutations can also cause an isolated hypomyelination with variable cerebellar atrophy, but without the classic striatal abnormalities seen in the original cohorts. And thus we began to understand that there was a significant phenotypic spectrum of the disease. We don't fully yet understand how different mutations are responsible for these different phenotypic spectrums. But what we do understand is that mutations in the TUBB4A likely result in differences in microtubule dynamics. So there are beta tubulins and alpha tubulins, and different cells express different types of alpha and beta tubulin, but throughout all cells, these beta and tubulin molecules aggregate as a dimer that then forms microtubules. And I direct you to a wonderful short movie called The Inner Life of the Cell, made by a group of researchers at Harvard, which really demonstrates in live, sort of a live action movie, the assembly and disassembly of these microtubules from tubulin dimers. And importantly, these different mutations are thought to potentially affect how the different components of these dimers attach to one another and attach within the microtubule, and also whether or not and how well the molecular motors that use the microtubules to transport cargoes throughout the cell may be able to attach to the microtubule. We think that these differences in mutations are the reason for different types of cellular effects. So as we started looking at these different mutations in cells in a dish, it became clear that certain mutations resulted in primarily neuronal involvement, primarily the disorders such as whispering dysphonia with that mild presentation that we discussed earlier. Other disorders resulted in isolated hypomyelinating disorders and also primarily oligodendrocyte involvement, whereas the classic HABC presentation resulted in involvement in both neurons and oligodendrocytes. And specifically, there's a single mutation that's highly overrepresented in the classical HABC presentation. At this point, teams are working on modeling HABC to better understand how microtubule dynamics results in cellular dysfunction. And we're lucky in that if you disrupt the TUBB4A in a mouse, you can replicate the disease phenotypes seen in humans with gait abnormalities, early mortality, as well as specific cellular abnormalities, including striatal neuronal loss, oligodendrocyte loss, and lack of differentiation, resulting in recognizable hypomyelination, both in EM and histology, as well as cerebellar granule loss. And it's the hope that these models will permit better understanding of the disease mechanism and also testing of therapeutics. Despite our relatively recent understanding of this disorder and our only emerging understanding of its molecular mechanism, this is an important disorder to recognize because it's much more frequent than might be otherwise expected. I've shown earlier today data from this study on a panel of genes looked at on whole exome sequencing results, and you can see that TUBB4A is the most frequently identified hypomyelinating leukodystrophy, well ahead of disorders that might be more familiar to you, such as Pelizaeus-Merzbacher disease. And so it is not improbable that you will see patients with this condition. The most common presentation of TUBB4A mutations is that late infantile presentation with relatively preserved cognition and significant motor impairment, as seen in these two little girls who had significant spastic diplegia, required a wheelchair for most of their mobility, but became fast friends at a family conference that we hosted for this disease. So as we have grown to understand the natural history of TUBB4A-associated leukodystrophies, we now understand that there's likely three main cohorts. The first cohort is an early infantile onset presentation. These patients tend to present with early onset encephalopathy, profound lack of acquisition of milestones, even including head control, and may have associated features such as seizures. At the very other end of the spectrum, extending all the way into the adult onset dystonia, there are patients who present with a very mild phenotype, sometimes with a childhood presentation rather than an infantile presentation, and may have neurobehavioral effects such as ADHD as well as spastic diplegia. In between, there's a intermediate phenotype, typically with a late infantile onset phenotype with preserved in early speech and ambulation, even if lost over time, and relatively preserved cognitive features. The canonical mutation associated with HABC is overrepresented in this phenotype and remains one of the most common mutations seen in approximately a quarter of overall reported TUBB4A mutations. Importantly, this variable phenotypic spectrum can be associated with age of onset, such that the early severe onset patients tend to present before 12 months of age, and then the patients with both D249N mutations and the other patients without D249 mutations in that moderate spectrum will likely present in a much more variable age group, and then a cohort of patients presenting sometimes much later in life in the very mildest presentations. This is shown in a different way with the age of onset of the more severe presentation, again being typically before 1 year of age, whereas the very mildest presentation being much older, and the D249N patients closely aligning with the intermediate form of the disease. Importantly, when looking at acquisition of milestones and the percentage of patients who ultimately gain independent ambulation, the patients with the intermediate late infantile presentation, in a majority of cases, acquire independent ambulation, particularly if there's a D249N mutation, and the patients with an early onset presentation before 12 months of age are far less likely to gain independent ambulation. Although the patients with the D249N mutations more reliably gain ambulation, they also more reliably lose ambulation, often within the first 10 years of life. So here you see a rapid earlier loss of ambulation in the patients with D249N relative to those patients who have non-D249N intermediate presentation. And there's also an earlier time point to requiring a G-tube in those patients who have the D249N mutations relative to the patients who do not have D249N mutation but have a moderate late infantile presentation. So overall, within the three groups we described, patients who don't gain early milestones and present well before a year of age are likely to have a severe neurodevelopmental outcome and require significant support. Then a much milder presentation, often happening after a year of age, will include some patients who have long-term preserved skills such as ambulation, with an intermediary cohort presenting in the late infantile period in which the association of with a D249 mutation will result in a more consistent gain of milestones such as ambulation and speech, but also a more consistent early loss of milestones before the end of the first decade of life, often requiring G-tube placement. Importantly, anticipatory guidance is important, as in all atrophies, and patients with TUBB4A mutations may have significant orthopedic complications related to their leukodystrophy and to their dystonia, and will be even more likely than certain other leukodystrophies to result in profound orthopedic disruptions such as scoliosis due to the severe and persistent dystonia seen in this disorder. Dystonia and spasticity are complex problems requiring multidisciplinary management, and these patients should be availed of all the available modalities, including pharmacologic approaches such as not only baclofen but also drugs such as artane and Sinemet to try to manage the complex dystonia. We also recommend consideration of chemodenervation approaches as well as baclofen pumps as useful ways to manage the often significant tone challenges seen in these patients. To my knowledge, only a small number of patients have undergone stimulatory approaches to try to manage the dystonia, and these have not been reported to be significantly successful. Additionally, selective dorsal rhizotomy was contraindicated in this disorder, as it is in many other leukodystrophies, due to the fact that these patients suffer such profound and significant dystonia. Feeding concerns are an early and frequent problem in this condition. The dystonia affects swallowing in an unpredictable fashion, and even when patients are not having overt swallowing problems, we recommend that these patients have a very careful attention paid to choking risks, because there can be sudden and unpredictable difficulty with swallowing due to dystonia, and these patients present a significant choking risk for items such as hard candy and larger boluses of food, even if most of the time they tolerate chewing and swallowing without incident. So we recommend to these families that they continue paying attention to choking risks, as one might consider with a toddler, avoiding foods like hot dogs, large boluses of bread, hard candy, and nuts, even if they have no reported problems with swallowing. These patients also occasionally have significant gastric dysmotility, sometimes resulting in frequent periods of feeding intolerance, and that's poorly understood and not well elucidated. They also may have recurrent vomiting, again, for poorly explained reasons. They also, of course, have the same type of gastric and intestinal complications seen in most patients with profound neurologic differences, including reflux and constipation. But beyond that, there appears to be subtle differences also in their gastric function compared to other patients with leukodystrophies. There's a small number of patients who, for reasons that are not well understood, also have structural cardiac differences, and we therefore at this time recommend baseline cardiac echocardiogram for all patients who are diagnosed with TUBB4A. Patients with all types of leukodystrophies and profound motor impairments, especially if they also have orthopedic problems such as scoliosis, are also at risk for significant respiratory compromise, and we recommend that patients, if they have a significant motor impairment and or scoliosis, be followed by a pulmonologist for careful attention to lung hygiene and protective measures designed to improve their respiratory function. The spasticity and constipation seen in these patients can result in significant bladder dysfunction. It's not uncommon for these patients to have early and profound issues with urinary continence and recurrent UTIs, and this should be carefully managed in a multidisciplinary fashion to manage both tone problems as well as precipitating factors such as constipation or poor hydration, and to try to avoid urinary tract infections. Patients also may have differences in ocular function, not so much necessarily because of ocular differences per se, but also because they tend to have significant nystagmus in some cases, which may impact their ability to use their vision, as well as saccadic vision disturbances. And these patients should be referred for vision services, as they often have preserved cognition, and their vision is very important for using augmentative communication approaches to improve quality of life and academic achievement. And then finally, patients may have significant fine motor issues related to their cerebellar ataxia, as well as their spasticity and dystonia, and these patients should be availed of every augmentative approaches to permit their learning and development over time. And that concludes my overview of HABC and TUBB4A associated leukodystrophies. I hope this will help you recognize this important disorder that still remains underdiagnosed due to the fact that it's a relative recent arrival on the leukodystrophy scene and requires better diagnostic and therapeutic approaches. Thank you very much.
Thank you, Adeline, for that talk. I had a question while we're waiting for questions from others. What would be the key clinical features early in life that would point you to want to do testing for this disorder?
Thanks, Laura, for that question. I think thinking about this disorder amongst the other leukodystrophies, it may present, well before the pathognomonic MRI features of cerebellar atrophy and globus pallidus, particularly the caudate and putamen atrophy, are seen. And so you often see a child who has nonspecific hypomyelination. The two big early categories that I would use to think about testing would one be the child who's under 1 year of age and has such severe hypotonia that they don't really have any meaningful neck control while still having preserved social contact, because these children are very alert appearing but with profound hypotonia and lack of acquisition of developmental milestones. The second cohort is the toddler who presents with a hemidystonia after a period of previously normal or only mildly delayed developmental acquisition with a hemidystonia or with significant gait abnormalities with prominent dystonic features.
I have a follow-up question. Do you find that the dystonia tends to be responsive to medical intervention?
That's a great question. It's very there's a very moderate response. We have tried Cinemet as well as other techniques such as baclofen and Artane and other medications that are typically used to manage tone, and the dystonia is poorly responsive to those interventions, unfortunately. And I think that's a metric of the likely underlying cell death that is seen in our models of disease, and that it's not so much a chemistry problem per se, as much as it is actually a cellular loss, and unfortunately it can be very refractory to therapy.
Thank you so much for your insights today on HABC related disorders.